also to the honorable speaker for today's event, Mellissa Withers, PhD, MHS. Good morning, Mellissa.
Good morning. Nice to see you.
Yeah.
Also, the Honorable all the lecturers of Public Health Faculty, Universitas Airlangga.
Welcome to the Health Promotion Teaching, Health Sociology, and Anthropology held by the Division of Health Promotion and Behavioral Science, Faculty of Public Health, Universitas Airlangga.
I am Bagus.
And I am Gaby.
We are the students of Health Promotion and Behavioral Science, Faculty of Public Health, Universitas Airlangga, and today we will be your host for today's event.
And today's Health Promotion Teaching is a collaboration between the Faculty of Public Health and the Airlangga Health Promotion Center, or AHPC.
All right, so Airlangga Health Promotion Center, or AHPC, is a multidisciplinary institution that is intended to improve public health status internally at Airlangga University and externally at the communities around Airlangga University.
And along with AHPC, we have a peer educator project called Sobat Happy and Healthy, also known as SOBI, that is also part of AHPC. And today in this event, Faculty of Public Health, AHPC, and SOBI are collaborating to present the insightful talk regarding health promotions. Okay, all right. Today we're going to have insightful yet amazing discussion under the topic of Etnomedicine, Cultural Relativism, and Health Promotion.
Exactly, and this topic will be delivered by Mellissa Withers, PhD, MHS, coming from the Department of Population and Public Health Sciences, Keck School of Medicine, University of Southern California.
Yes, and I would like to greet all the audiences in this Zoom meeting. Good morning, everyone.
Good morning.
And also, okay, good morning, Ms. Riris. And also to all the YouTube live stream viewers, because today's talks are gonna be in live stream on Airlangga Health Promotion TV YouTube channel.
All right, ladies and gentlemen, to start today's event, let's together sing the national anthem of Indonesia, Indonesia Raya. Participants, please be prepared.
Okay, next let us sing the anthem of Universitas Airlangga, Hymn Airlangga. To all the audiences, please put your clenched right fist in front of your left chest.
All right. Moving to the next agenda, we are now going to listen to a few opening speeches.
Yeah, first we're going to have the opening speeches coming from the head of Health Promotion and Behavioral Science Division, Dr. Sriwidati SS MSc. To Dr. Sriwidati, time is yours.
Okay, thank you, Master of Ceremony, Mas Bagus dan Mbak Devi. Good morning and best wishes to us all. My name is Widati. I am head of Erlangga Health Promotion Center and Health Promotion Division in Faculty of Public Health, Universitas Erlangga. We thank God Almighty because of the blessing and His compassion, so we can gather at this event. Previously, I say welcome to Mellissa Witter, PhD from University of Southern California. Thank you for joining us and giving us a lecture today. Thank you, Mellissa. I really appreciate it, and this is very special moment for us in Erlangga and for me and my students and all of students and lecturers. Yeah, I also would like to say welcome to Prof. Dr. Ninyo Mantri Puspaningsi. She is the Vice Rector for Research, Innovation, and Community Development, Universitas Erlangga. Thank you, Prof. Nyoman, for joining. And welcome to Dr. Santi Martini, Dr. MKes, as Dean of Faculty of Public Health, Universitas Erlangga. Thank you, Pu Santi, for joining in the meeting. And we say thank you for all the present of all the lecturers and students in this meeting. And today we will follow the health promotion teaching. Yeah, this is health promotion is an effort to make people aware, willing, and able to maintain and improve their health status. And as we know, in Indonesia, there are lots of effort to make themselves healthier and happier. These efforts are often manifested in culture, in tradition, yeah, that is delivered from one generation to the next generation. So we have in public health, yeah, and health promotion, we have to understand the culture and the tradition in the context of the concept of health and illness from the local community. And in this health promotion teaching, we will study about the history, the existence and development of the concept and health, which is related with the local tradition and local culture. And the topic we call it Etnomedicine. As the lecturers and students, Etnomedicine is very important to understand. Why? Because considering that Indonesia is the big country with more than 1,000 ethnic group and more than 600 languages and more than 1,000 intangible cultural heritage, which consists more than 400 cultural heritage in the domain of community custom. Yeah, so this is very important for us to study the etnomedicine, yeah, and the cultural relativism and how health promotion use it to optimally to gaining a happy and healthy community. And we study the topic of etnomedicine in the public health, sociology, and anthropological courses. And now we can study it from Mellissa, PhD. And as we know, she is the expert from Department of Population and Public Health Science, Keck School of Medicine, University of Southern California, Los Angeles. Once again, thank you very much for joining, and thank you for Mellissa, PhD. Yeah, I think it's enough for me, and thank you back to the Master of Ceremony.
Okay, thank you very much, Dr. Sriwidati SS MSc, for the warm opening speech. Moving on, we are also going to have the next speech that will be delivered by the Vice Rector in Research, Innovation, and Community Development of Universitas Erlangga, She is Professor Dr. Ninyoman Tripuspaningsi, MSc.
Yeah.
To Prof. Nyoman, time is yours.
Yeah, thank you, Mas Bagus. Assalamualaikum warahmatullahi wabarakatuh. Very good morning for all honorable guests and also the participant, student, the leader of Faculty of Public Health, the Dean of the Faculty of Public Health, Dr. Santi. Good morning, Assalamualaikum. And also our honorable to our guest speaker today, this morning, Dr. Mellissa Withers from University of Southern California, Department of Population and Public Health Science, Keck School of Medicine, Los Angeles. So greeting, of course, from Universitas Airlangga. We are very pleasure to invite Dr. Mellissa and also all the participants today. We know that learning from the COVID-19, I think all of us realize that the important thing of the health. Yes, our government also already thought that this one is very important. So why Universitas Airlangga also as a part that mentioned by Dr. Widati, we are a part of the health promoting university, national for the health in Indonesia. So we have a mandate from our Ministry of the Health, Indonesian Ministry of Health, that we are supervising many university in east part of Java Island or east part of Indonesia also to promote the healthy or healthy and happy of the university. Campus is the main focus of this kind of the program because we know that the university or campus is part of the academia. We are also part of our society, and we, of course, also part of the community services and development. So why then our rector launched the Airlangga Health Promoting Center that already also mentioned by the MC and also Dr. Widati. And in this moment, I would like also appreciate and congratulate to the Dean of Faculty of Public Health, who always support the Airlangga Health Promoting Center. And of course, also appreciate to Dr. Widati and her team in Airlangga Health Promoting Center. This congratulations for all of the public health academia and also Civitas Academia and also then all the researcher and also alumni, because Universitas Airlangga just got 4-star rating for the healthy campus or health promoting university. So congratulations, because this is done by the public health faculty, of course, the Dean of Dr. Santi, and also with the team of Airlangga Health Promoting Center. Without their support and all the team in Faculty of Public Health, I think that Universitas Airlangga cannot getting the best, even though we are in the 4. The best star is 5, but we are almost near 5 that the jury told to us. So we hope that this year we can achieving for the 5-star for the health promoting university. So why the Airlangga Health Promoting Center is very active to do or to promote how to live in the healthy and also happy. This is very important because we know this this situation for the health something changing. Yeah, it's not like before the COVID. We know that in the future we have so many challenges, but this one also give us so many opportunity to do better and better in this situation. So in Indonesia, we know that healthcare is now very important also. We learned so much from COVID-19, and we thank to Dr. Mellissa that she would like also to share with us today, this morning, about ethnomedicine, cultural, and also relativism and health promoter. So Indonesia that mentioned with also Dr. Widati that we are very unique because we have so many islands. We are archipelago countries. We have around 70,000 islands. So I think all of us can imagine how then the very multiculturalism in Indonesia. We have so many kind of the specific culture in each island or also maybe in its local area. So this is very unique, but this one is very interesting for us because we can more giving tolerance and also more strong in interaction with all of Indonesian people in many places in the island of Indonesia. So ethnomedicine, I think the study is, this one is very important of health and also healthcare in the communities regarding to the tradition, culture, yeah, and also belief held by local community or local ethnic city. For me, I think this is very new and very insightful for Universitas Airlangga for this kind of the topic and the activity to promote the health and also healthcare among the academia, student, and also researcher. And we hope Dr. Mellissa or Mellissa with their PhD, we hope that in the future you can visit us in Universitas Airlangga, Dr. Mellissa, and join our community program. Universitas Airlangga is also secretariat of WUACD. WUACD is World University Association for Community Development. So part of them, I think, health and healthcare becoming very important. So we can giving contribution or impact to our society is not only academia in campus, but also community in local or national and also in the global area. So in this opening speech, I also would like to share to all of the participants, researcher, also the expertise, and of course to Dr. Mellissa, that this year we also will build a new center like Airlangga Health Promoting Center, but this is more in the Indian Ocean Studies. So we call it Airlangga Institute for Indian Ocean Crossroad. So it's mean that this one is the one that in the global network, we are part also from the International Institute of Asian Studies in Europe. This is the headquarter base office is in Leiden University in Netherlands. And the network is not only built in Universitas Airlangga as a part of Indonesia representative, but also in Singapore and in Thailand. So also in Africa. So I hope that in the future, Airlangga Health Promoting Center can do together, hands in hands, with the Airlangga Institute of Indian Ocean Crossroad. So we can do about the health promoting teaching or health promoting campus or university for the health and also healthcare, health and happy, the society. With Dr. Mellissa, we can invite you to join this kind of the institute to do together related to the health promoting university. So because this kind of the institute will more contributing for the society and community, like more in community services or development and health. I think the one of the important thing that we can do together with this institute and also WUACD. So WUACD, Dr. Mellissa, we have around 30 members now. And also we have one member from USA, is Miami-Dade College. So we have also, we hope in the future, your University of Southern California also would like to join with us, so we can do more meaningful of community services and development on the health promoting university, or also in the teaching and learning and more activity for our community. I think this is that we also would like to share to all participants, and also to especially to Dr. Mellissa. And thank you very much for joining our program today and sharing your expertise with the participant. Of course, will be very useful for us. This is very fruitful also for us to learn many things with you. Thank you very much. Selamat mengikuti Bapak Ibu sekalian. Saya mengucapkan terima kasih pertama kepada Dekan Fakultas Kesehatan Masyarakat yang selalu mensupport kegiatan-kegiatan yang terkait dengan promosi di bidang kesehatan, dan juga AHPC ini larinya sangat kencang, Dr. Santi. Kami sangat mengapresiasi. Kemarin kemarin mendapat penghargaan dari Presiden Mahidol terkait dengan AUN program untuk rating tentang Health Promotion University ya.
Selamat buat UNER juga, Prof.
Iya, terima kasih. Tentunya tanpa supportnya FKM ini, teman-teman yang ada di para dosen, para mahasiswa, ini pastinya UNER tidak bisa mencapai yang prestasi seperti ini ya dalam 1 tahun AHPC ini. Kemudian juga apresiasi juga ke Ibu Widati, Bu Ira, ini larinya kencang semua ini timnya, Ibu-Ibu Kartini ini, dan tim AHPC luar biasa. Mudah-mudahan semangat terus gitu ya untuk membantu tidak hanya kampus UNER tapi kampus-kampus lain sesuai dengan mandat dari Kementerian Kesehatan dan juga masyarakat Indonesia. Tentunya harapannya nanti kita akan bisa lebih memperhatikan terkait dengan bidang kesehatan ataupun untuk menjadi sehat dan bahagia gitu ya untuk masyarakat Indonesia. Saya rasa itu dari saya. Jadi sekali lagi terima kasih untuk kegiatan yang sangat bermanfaat ini. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih supportnya Prof. Nyoman.
Sami-sami Dr. Santi, Bu Widati, Bu Ira. Saya kembalikan ke Mas Bagus, Mbak Gabriel.
Yeah, terima kasih Bu Nyoman, Prof. Nyoman. Thank you, Prof. Nyoman, for the speech. And now we're going to listen to the last opening speech before we're going straight to the main talk. This speech will be delivered by the Dean of Faculty of Public Health, Universitas Airlangga, Dr. Santi Martini, Dr. MKes. So, Dr. Santi, time is yours.
Ada tadi sudah dibuka sama Prof. Nyoman ya. Oke, harus.
Tidak apa-apa, Bu Santi yang tak paham ilmunya bisa memberikan masukan. Kalau saya masih belajar nih Bu Santi.
Iya, matur nuwun Prof. Nyoman. Saya mungkin delivered in bahasa ya, karena Mellissa, Dr. Mellissa ini pinter bahasa Indonesia, Prof. Nyoman.
Oh, oke.
Pernah tinggal di Indonesia, di Bali, tempatnya Prof. Nyoman.
Oh iya. Dia sangat hafal Nyoman, berarti nama Bali, Dr. Mellissa. Oh, sudah ini ya, paham ya.
Iya.
Banyak Nyoman di Bali.
Baik, Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sehat, salam sejahtera buat kita semua. Allow me to deliver in bahasa ya, Dr. Mellissa. Selamat pagi. Pertama-tama kami menyampaikan terima kasih yang terhormat Prof. Nyoman sebagai Vice Rector for Research, Innovation and Community Development. Thank you very much for your coming and also always support us, Prof. Nyoman. It's very important for us to do everything. Yeah, and also selamat pagi kepada Dr. Mellissa Withers from Southern California University ya. Terima kasih. Thank you very much for providing your time to share your knowledge with us. I think it's we have a different time. It's very struggling, I think, because now is evening or always night in US. So thank you very much. Terima kasih banyak Ibu Mellissa for your time. Dan juga pada yang terhormat Ibu Widati sebagai Ketua atau Koordinator Airlangga Health Promotion Center. Ini lembaga baru di UNER, tapi luar biasa seperti yang disampaikan oleh Prof. Nyoman, aktivitasnya kencang larinya bersama Ibu Ira dan tim ya, sehingga alhamdulillah UNER bisa mencapai dapat bintang 4 ya di Health University Rating System. Ini prestasi yang luar biasa, belum sampai 2 tahun ya, bahkan mungkin dalam waktu 1 tahun sudah bisa. Dan juga tentunya terima kasih kepada para mahasiswa yang menjadi tim dari AAPC ya, dan juga selamat datang. Dan juga yang saya hormati dan banggakan para peserta partisipan yang hadir pada webinar Etnomedicine pada pagi hari ini yang hampir mencapai 250 ya pesertanya. Belum lagi yang ada di YouTube ya, karena ini live streaming ke YouTube Prof. Nyoman ya, Ibu Mellissa ya. Jadi karena kita tahu ilmunya Etnomedicine ini sangat penting sekali, dan kami berharap nanti sesudah ada pertemuan atau webinar ini, I do hope that we can develop a joint activity between Southern California University and Universitas Airlangga, such as joint research, because in our university we have also pharmacy faculty, and also we have a nursing faculty. Maybe we can have a joint research or joint publication and joint community development, as Prof. Nyoman mentioned before. Yeah, so Bu Widati dan Bu Ira, saya minta bantuannya, mungkin nanti kita bisa kembangkan kegiatan ini tidak hanya dalam bentuk webinar, tapi nanti ada activity berikutnya yang menjadi kolaborasi antara Southern University, Southern California University dan Universitas Airlangga. Saya rasa probabilitasnya, peluangnya sangat besar, karena kita tahu Universitas Airlangga have many funding ya, Prof. Nyoman ya. We have our rector provide many funding, Dr. Mellissa. Yeah. So I think it's very possible that we can develop a joint research or joint activity between UNER and Southern California University. Dan kita juga we have experience to have what we call to menerima, to accept a student from abroad ya. I think in the early of this year we have 20 students from Griffith University, and also collaboration with Fakultas Sosial dan Politik, and also we have 20 students from Federation University Australia. They have an agenda related, an activity related to health promotion in Surabaya and in East Java. And the person who have in charge is Ibu Widati and also Ibu Ira. So I think we can also welcoming your student to come to our campus, Dr. Mellissa. I think it's very possible, yeah. And next month in June we have also a student from Yale University, and in September we have also student from Western Australia. 10 students will be coming, yeah, to learn about health promotion in Indonesia and specifically in East Java or Surabaya. So I think it's very possible. So you can come, I think in October, ya Prof. Nyoman ya, WUACD ya.
Yeah, October.
Yeah, you can come with your student in October. I think it's very possible, Dr. Mellissa. Yeah, we have many activities. Yeah. So for this activity or this webinar, we are very glad that Faculty of Public Health collaboration with AHPC, Universitas Airlangga, to have this issue, because this issue is very important, as Bu Widati mentioned before, that we have various ethnic, various apa ya, suku itu apa? Yeah, various ethnic, various suku, and various culture. Yeah, so we have to learn about culture is very important. Yeah, so I think the last word from me. Thank you very much again for providing your time with us, Dr. Mellissa, Ibu Mellissa, and also thank you very much also for Prof. Nyoman for always support us. Yeah. Especially Faculty of Public Health, Prof. Nyoman. Ya.
Sama.
Seperti kemarin yang dari NCP program itu juga atas support Prof. Nyoman, sehingga semua bisa berjalan dengan lancar seperti yang kita harapkan, dan mereka sangat puas, Prof, atas aktivitas yang kita siapkan, dan tentunya ini juga atas support dari Prof. Nyoman sebagai Rektor RICD. Ya. Dan juga terima kasih pada student yang sudah hadir pada pagi hari ini. Tetap setia sampai selesai ya, dan dimanfaatkan betul Ibu Mellissa ya. Silakan tanyakan berbagai macam hal dan diskusikan dengan beliau, dan bahkan mungkin ada program-program mungkin Anda juga bisa tanyakan, program-program yang di-provide oleh Southern California University, sehingga Anda juga mungkin bisa mendapatkan kesempatan untuk bisa belajar langsung di sana. Baik, sekali lagi terima kasih para mahasiswa, dan tentunya juga terima kasih pada panitia ya, yang sudah menyiapkan kegiatan pada pagi hari ini, Mas Bagus, Mbak Gabriela, dan tim. Terima kasih sekali ya. Baik, saya akhiri. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Santi, for the remarkable opening speech. As what Dr. Santi mentioned before in the speech, that please, to the participants, keep watching the webinar session today until the end of the session, because we are going to have an insightful yet amazing discussion. Okay, so before we enter the main agenda today, I would like to ask all of the participants to turn on your camera, please, because we are going to take photos. We're going to take some photos as the documentation. So please, to all the participants, please turn on your camera for a while. We are going to take some photos. Bapak, Ibu, dan teman-teman sekalian mungkin bisa untuk mengaktifkan kamera terlebih dahulu untuk diambil gambar oleh teman-teman panitia. Baik, mungkin saya persilakan pada teman-teman panitia.
Ayo semua buka kamera dulu, mahasiswa ya.
Baik, Bapak, Ibu, dan teman-teman mungkin yang belum menyalakan kamera boleh terlebih dahulu menyalakan kameranya, karena akan diambil gambar sebentar oleh teman-teman panitia sebagai bentuk dokumentasi. Saya persilakan kepada teman-teman panitia mungkin untuk bisa mengambil gambarnya. Ya, silakan Mbak Meza mungkin.
Thank you, so I will count in 3.
Okay, maybe I will help for counting. Is it okay, Mbak Meza? Okay, let's do one more time. 1, 2, 3. Okay. Thank you very much to all the participants for turning on your camera.
Okay, next. All right, ladies and gentlemen, as I mentioned before, that today's teaching will be delivered by Mellissa Withers, PhD MHS from University of Southern California. And in order to get to know our speakers, let me read the curriculum vitae of our speakers for today. For the operator, can you please share screen the curriculum vitae? Untuk yang bertugas mungkin boleh minta tolong untuk bisa menampilkan kurikulum vitae dari speaker kita pada hari ini. Iya. Baik, sambil menunggu, saya akan langsung bacakan. Let me read the curriculum vitae for our speakers today. Our speaker is Mellissa Withers, PhD MHS, with the research interest in global sexual and reproductive health and women's empowerment, community-based participatory research, gender-based violence, mental health, and pedagogy. And Mellissa had her latest educations in PhD from University of California at Los Angeles at School of Public Health Community Health Science Department in 2009. And also she earned education in Johns Hopkins Bloomberg School of Public Health and also University of California at Berkeley. For the employment experience, there are lots of excellent employment experience. I will read the latest from 2013 to present as associate professor in University of Southern California, Department of Population and Public Health Sciences, Keck School of Medicine, Los Angeles, and also as directors of online MPH program from November 2021 until now. Mellissa also has employment experience as director of Global Health Program from January 2013 until now as in Association of Pacific Rim Universities in Hong Kong. There are also lots of experience in employment. There are also in grants and consultancies since 2015 as the co-investigator in meeting the needs of women of color living with HIV to improve resilience and ART adherence during the COVID-19 pandemic and beyond in the USC Provost Office Strategic Directions Grant, and also in 2023 in the role of co-principal investigator, and the title is Campus Sexual Assault Response to LGBTQ Students in California Governor's Office of Emergency Services, and a lot of consultancy that been already done since 2015. And also Mellissa had done a really much peer review publication, and her latest one is in the title of Psychological Barriers and Enables to Disclose Intimate Partner Violence Among Asians Immigrant Women in California, Cultural Health and Sexuality. It's reviewed in 2023. And there are also lots of books and book chapters that Mellissa has written. The latest one is in 2022. It is Looking Ahead While Leaving No One Behind, Resourcefulness and Resilience Among North American Universities in the Safety and Resilience of Higher Education Institution Post-Pandemic Analysis.
Assalamualaikum.
And also, there are a lot of popular press and online articles written by Mellissa. You guys can see in this curriculum vitae, and also a lot of abstracts and presentations since 2015. And also Mellissa had already editorships and editorial boards from 2016 and until 2012. And in this latest, he already do editorships and editorial in Associates and Journal of Public Health Emergency. And also, Mellissa, fluent in Spanish, beginner in Japanese, had already studied in a bilingual program in 11 years and also fluent in Bahasa. So that's all a really excellent curriculum vitae of Mellissa Withers, our speaker for today. And there are still a lot of publication and inspirational experience from Mrs. Withers.
Wow. Okay. So now let's get to meet Mrs. Withers. Hi. Good evening, Mrs. Withers.
Hello, nice to see you all.
Nice to see you too, Mrs. Withers. How are you today?
I'm doing fine. How about you?
I'm doing fine too. Yeah, great. Okay, so for the next 90 minutes, Mrs. Withers will deliver her topic. And for all of the participants who have questions, you can ask directly at the Q&A session, or you can write down your questions either in the Zoom chat box below or in the YouTube live comment sections. All right, so Mrs. Withers, time is yours.
Thank you. Thank you so much. It's wonderful to be here. I have a special place in my heart for Indonesia, although it's been a few years since I spoke Bahasa, so I need to practice. But I did my dissertation research about 15 years ago in Bali on maternal health and fertility intentions. And so I'm always delighted to speak to Indonesians and to go back to Indonesia to visit. So I definitely would welcome some further collaborations with you all. So I'm very honored to be here. So thank you once again for the invitation. And it was a great background to hear more about your university and the center. I was really quite impressed to hear about your community connections and all of the work that's being done directly in the community, which is something also that I try to promote here in the United States. And the fact that you have a Department of Health, Sociology, and Anthropology, or a program, that's really fantastic. So as you probably saw from my CV, I did my doctoral program, I got a minor in cultural anthropology, focusing on medical anthropology. And the reason why I chose that field is because it's really hard to separate health promotion and public health from culture. Culture is such an important factor in people's understanding of disease and of health, and people's utilization of healthcare services. So we really cannot promote public health and the health and well-being of people really without considering all of the cultural factors and cultural barriers that go into these decisions about health. So I'm very happy to talk to you today about this topic that I love very much. And again, as was mentioned, feel free to put any questions you have in the chat. It can be interactive if you want. It's great to see over 250 people attending today. That's wonderful. So hopefully I can keep you interested for the next hour and a half or so in my talk. I think Indonesia also has many strengths around maternal health, which is one of the topics that I'm going to talk about, and public health in general. I know one of the books that I edited on case studies, we had 13 case studies from around the world, and we featured Indonesia as a model for providing maternal health services especially in remote areas, and including the community in helping to ensure that pregnant women get healthcare access when needed. Of course, we know also that Indonesia is really a model for in terms of family planning programs, and I was very impressed when I lived in Bali when I did my dissertation work to learn more about the Posyandu model as well. So I really think that it should be really bi-directional. We can learn a lot, I think, from the models and the public health programs that you in Indonesia have put in place as well. So let me then share my slides and we can begin today's talk. Okay, so I am titling my talk Cultural Barriers and Idioms of Distress, Cultural Relativism, and using examples from maternal health and also from mental health. So let's start off with what exactly do I mean? What does cultural relativism mean? Well, maybe you have already heard of it, but we're thinking about things like practices that may be common in other places that may not be common in your country. So have you ever seen, or eaten food in another country or in a different way? So some people might think, it's normal to eat with your hands where other people don't. Other countries might like to eat live squid where others don't. And I recently was in Vietnam where we ate fried crickets. Okay, so some people might think this is weird. This would be an example of ethnocentrism. That means that you're using your own culture as the center of your world and your perspective and your worldview, and you're evaluating other cultures or judging other cultures based on your worldview. So we all make assumptions about food of other countries or beliefs or practices of other countries or cultures that are different than our own based on our own norms or values and beliefs. So Chinese people traditionally eat noodles and peaches for their birthday celebration, where in my culture, we typically eat cake, right? There are sweeping generalizations about certain groups of people that don't drink milk, but we know that maybe they are reluctant to consume milk and other dairy products because of lactose intolerance, right? Not necessarily because of cultural beliefs, but judging other cultures' values and beliefs without really understanding them or appreciating them can lead to ethnocentrism. So it's defined as beliefs that your own culture is superior to others and seeing the world as centered around your country or culture. So these values are very much associated with colonialism. And it is tied back to seeing really during colonialism, seeing other cultures as inferior or savage, right? Which very much led to discrimination, to hate, intolerance, and racism, and has been used to justify colonialism and domination over many generations. Cesar Chavez is one of our heroes in the United States. He was here in California. He was a fruit picker, and he led the movement of rights of farm workers. And he says, preservation of one's own culture does not require contempt or disrespect for other cultures. So here are some examples of ethnocentric beliefs. We may judge other cultures' dress or appearance. We may criticize their dietary preferences or behaviors. Americans are famous for expecting everyone else in the world to speak English, even if you're not in the United States. There are some cultural practices in mainstream US that may not be accepted in some cultures. For example, public displays of affection may be very frowned upon in other cultures, or public breastfeeding might not be acceptable. In some cultures, showing strong emotions is not acceptable, or even using toilet paper or practices associated with bathrooms. So we have to be tolerant, and we have to be careful of, again, of judging other cultures through an ethnocentric lens. So cultural relativism is the view that ethical and social standards reflect the cultural context from which they come. So people who subscribe to cultural relativism believe that cultures fundamentally differ from one another. And so the frameworks that structure relations and values and practices in those cultures are very much based on the context. And cultural relativists say that deciding what is right or wrong by evaluating it according to our standards is not correct. Instead, we must evaluate it according to the standards of that society in which the action occurs. So really, value judgments should not be made across cultures in many situations. Instead, really, we need to understand the cultural practices of other groups within that context. You may ask ourselves, why do they do it this way in this culture? Where do these beliefs come from? And so if we think about their customs in a way that helps us make sense of their culture and how these practices fit within the overall cultural context, we will be doing really a favor, right? It'll be a much better appreciation of that local culture. So cultural relativism roots really came out of a German-American anthropologist, Franz Boas, in the early 20th century. And he actually was quite ahead of his time. He was born in 1858 and died in 1942. He has been called the father of American anthropology. And his work has been associated with cultural relativism, among other things. So back in that time, there was a lot of beliefs about eugenics and a lot of racism. And he said that he really worked to demonstrate that differences in our behavior, in our human behaviors, were not determined by biological dispositions, like what was being widely purported at the time. Instead, he said the differences in our behaviors are largely the result of cultural differences. And these behaviors are acquired through our social learning and being in that context. So he introduced culture really as the primary concept for describing these differences between behaviors in different groups. And again, rejected very much the very popular evolutionary approaches to the study of anthropology. In fact, he said that we should reject this research because it was mainly conducted by white, wealthy, and Western men who were doing research on people of color, on foreign indigenous populations, on poor people. And the research was being done with that framework of colonial beliefs, of superiority beliefs. And in fact, the research then is very much flawed. So I think this is a very good chart to show you some of the differences between ethnocentrism and cultural relativism, which are the ones that I really just described. But the main purpose of this is to say that people who subscribe to cultural relativism, and I think all of you in health sociology and anthropology should subscribe to cultural relativism, we must understand that one culture is not better than another. Cultural relativism matters. By recognizing our own biases and our and cultural relativism, we can recognize how much our own culture shapes what we believe as beautiful or funny or weird or good or bad. It helps us to understand, again, this maybe unconscious process that we use that is biased to understand the rest of the world, that we know that these biases shape our perceptions and reactions to the world. But it also helps us to make sense of different cultures. And that includes, just like the United States and just like Indonesia, not just our cultures across different countries, but also the different cultures within our own countries. And I would say even the different populations or subgroups within our own countries, whether it's different ethnic groups, but also it could be different class, it could be different religion, it could be different sexuality, right? Lots of different groups. So cultural relativism really does promote this understanding and tolerance, the idea that there are many cultures in the world and that each culture has its own values and beliefs and practices that have been developed over time. And none of, a culture, no culture is necessarily right or wrong. So what I do want to point out, though, and it's very important to note, that we also have to respect human rights. So true cultural relativists argue that human rights were developed by Western countries and they're based on Western values. And again, that they take a very extreme approach to saying that we cannot judge any other culture. But I would argue instead that we must balance societal, collective, and individual rights and interests. So we must protect any individual rights. For example, under the Universal Declaration of Human Rights, right? So we cannot use cultural relativism as an excuse to allow for violations of individuals' human rights. So let's talk about this. The UNESCO, there are some important international documents that help us to understand the limitations. For example, UNESCO says that no one may invoke cultural diversity to infringe upon human rights guaranteed by international law. And that we must protect people's cultural heritage as long as their practices don't violate international human rights. So here are some examples. We may be probably not harmful. Our differences in cultural beliefs and practices around hygienic rituals or bathing rituals, or maybe birth positions, or pain displays, or ideas about body shapes. But obviously, if there are practices that are harmful, such as child labor or child marriage or female genital mutilation or genocide, then we have to protect the human rights, right, over cultural beliefs. So in summary, this first part of my talk says that ethnocentrism is the idea that believing your culture is superior, but cultural relativism says that standards reflect the cultural context in which they are derived. And so we must evaluate practices and beliefs according to that society. However, we must also recognize and promote the universality of individual human rights. So my next part then is related, and it's about explanatory models of illness, which I really find fascinating in learning about different cultures. So what do we mean by explanatory models of illness? So it's just the way that people perceive or understand, interpret, and respond to illness. And so it's not only determined by the illness itself, but also by one's culture and social context. So according to a very, biomedical model, health just may mean you are free from any disease or pain or defect, but it doesn't really consider the role of social factors or individual subjectivity, where we know that traditional medicine takes a more holistic approach to illness. What I think is really fascinating is you can take two people that may have the exact same problem, the exact same illness or disease, but they may describe it, they may feel it, and maybe understand it completely differently. They may think that they have even completely different diseases despite having the same disease because of how they of these explanatory models of illness. So this was actually developed, this idea was developed in the 1970s by a psychiatrist, Arthur Kleinman. And again, he really said that individuals and groups and cultures can have very, very different understanding of health and disease. So he says, in fact, these are often culturally determined beliefs because they are shaped by and shape societal expectations of what someone is going to be experiencing, or how the disease or illness is going to manifest in that culture. It also helps explain differences in behaviors of the patients, and even when and how they get help. So again, each experience of a disease may be felt very differently according to a different patients. And I think our interpretation of health and disease is still very much focused on a biomedical approach, right? We talk about the biology of the disease, the biological causes, the side effects that happen in the body, the physical aspects of the disease etiology. But explanatory models may emphasize more about social or cultural context, and of course are shaped by people's prior experiences and about their own cultural beliefs. So it's also important for our physicians to understand this, because people may be trying to explain what they're feeling in very different ways. A lot of people outside of Western cultures have a much more holistic concept of disease and health. It may include a spiritual aspect of disease causation, in addition to biological and even psychosocial concepts. So this biomedical concept of illness, particularly when we're talking about infectious diseases, really resulted in trying to modernize medicine. And that came again from colonization, which tried to kind of force a very biomedical explanation of health onto non-Western cultures. But we know that even contemporary research shows that many people in other countries still hold on to a much more holistic concept of health. And then they may include supernatural or spiritual aspects of disease, not just biological. And they may also use both traditional and Western or modern forms of medicine, sometimes at the same time. So whether they think that the disease is caused by, say, a spiritual force, then they may go to a traditional healer. They think the disease is caused by a virus or a bacteria, then they may seek more formal care. And so it's really, I think, important for us to understand the impact that these beliefs have on health behavior and health seeking. It also will influence their receptivity to your health promotion campaigns and the messages. So both in terms of preventing a disease or illness and seeking treatment for a disease or illness. So all of this is really determined by their own explanatory models of a disease. So it's really important for medical professionals, but also for public health professionals to understand these beliefs, because then we can tailor our programs towards changing health behaviors in a way that's going to be more effective. So in many cultures and health systems, the approach might be much more social than just biological, even when the body itself is being affected, there may be social factors behind, that play a major role. So a disease may be explained by feeling lonely, right? Or socially isolated may cause you to be depressed, for example. So that's there are many examples of this. So Arthur Kleinman came up with these famous 8 questions that he believes physicians and medical professionals need to ask their patients in order to understand their beliefs and by understanding their patients' own needs and beliefs and expectations, the physician can create a treatment plan that's going to take into consideration the patient's behaviors and beliefs. And so he came up with these 8 questions that he thinks will help the clinician have a clear understanding of the patient's own explanatory model of the disease. So this is really an important tool to facilitate cross-cultural communication, to improve physician-patient communication and understanding, and ultimately to create better treatment and better outcomes for the patients. So the questions are things like, what do you think caused your problem? Why do you think it started? What do you fear about it? What kind of treatment should you receive? So I'm going to give you a couple of examples from my own work. One example is I've done some work over the past 10 or 12 years about Alzheimer's disease in Latinos in Mexico and in the United States. So this particular form of Alzheimer's disease is very aggressive, very early onset. Most people develop symptoms even in their 40s, and they tend to die very soon after, within a few years. Well, we talked to a lot of people about what they believed the cause of this particular rare form of Alzheimer's was. And we found that a lot of people associated with Alzheimer's with bad habits, about being cursed by God, about a supernatural or somebody putting a curse on you. And some people even thought that this kind of memory loss and confusion, that this was just normal. As you get older, this is just normal. You forget your keys, you get lost coming home from work, and that there was really nothing they can do. Well, you can imagine that if people believe that the disease is caused because they have had bad habits, and they're going to be blamed for creating their own disease, then they may not want to tell other people about their symptoms. They may try to hide them, right? They may try to suppress them and say, oh, nobody else needs to know until it gets bad. Or if they believe that it's a curse or a curse by God, for example, then they may have these fatalistic beliefs where they say, well, nothing I can do about it. It's just fate. And so I'm not going to seek treatment because it's just predetermined condition. Okay, so we know, in fact, that there are certain groups, racial and ethnic minorities, that believe, much more likely to believe, that Alzheimer's disease and dementia are just normal. And so they may not be alarming at all. But we know that these different expectations about what happens to your cognition or to your memory as you get older is going to influence whether they go to seek treatment. And we also know that they have Asian Americans or Asians believe much more in fate than other groups, where we found that Hispanics and African Americans believed much more in fatalistic, or it's just God's will. There's nothing I can do. We also know that racial and ethnic minority groups were also much more likely to attribute Alzheimer's to smoking, to alcohol use, to stress, and that they believed that it wasn't really a physical problem, but that it was a mental problem, and that it just meant the person was going crazy. So of course, this is going to increase stigma, both of the patient and of the family. But there's a lot of shame and embarrassment and hiding of the symptoms because of the stigma associated with this disease. So let me give you another example from my work on infertility. So we also know that understanding how infertility causes and etiology is described or understood in a culture can also help us to understand the decision-making process about when to seek care and if someone's going to seek traditional or more Western care. So in many cultures, infertility might be managed through informal or traditional or spiritual healers compared to Western healers or providers. And it's often linked to explanatory models about the cause. So in some cultures, right, you may go and seek maybe managed through herbalists or certain kinds of treatments that are more plant-based. You may go to a spiritual healer and give an offering, sacrifice. If you believe it's caused by an evil spirit or something like that, then you may visit a traditional healer. And so we know that, again, how someone perceives the cause of the illness or the problem, in this case, infertility, is going to influence whether they get care and what type of care they can get. So, any questions so far? Otherwise, I'll continue to some examples. Any questions or comments? Okay, well, I'll move on and then we can I don't see any hands up. We can continue. So I'm going to talk a bit about maternal mortality and how culture relates to maternal mortality. So we know about every 2 minutes around the world, there is a woman who is dying due to a maternal related cause. Think of the loss of 300,000 women around the world each year, many of whom are young, very young, just starting out their lives. We're losing potentials, mothers, scientists, wives, sisters, workers. Maternal mortality means that about 810 women die every single day from preventable causes simply because they got pregnant. We know that about 99% of maternal deaths happen in low-income settings, mainly sub-Saharan Africa and South Asia, like India and Nepal. And so they're almost always preventable. That's what's really, I think, saddest to me, is they're almost always preventable. Globally, the maternal mortality ratio is about 240 deaths per 100,000 live births. But look at the disparities between low-income and high-income countries. In high-income countries, only 11 women die per 100,000 live births, compared to 462 in low-income countries. So to me, this is very much an issue of social justice because we know how to prevent it. So why do we accept that a woman is going to have such greater chance of dying simply because she was born in a village in sub-Saharan Africa or in the mountains of Pakistan, right? Take a look at this. Look at this chart. We can see that many countries, again, in sub-Saharan Africa and parts of Asia, including Indonesia, right, have much higher rates than the global, even the global average of 240. And if we look at another way to think about maternal mortality, instead of using the maternal mortality ratio, we can use lifetime risk. So lifetime risk includes both the maternal mortality ratio, but also the fertility rate. In many cultures, women are only going to have one child. So that means they have one chance of dying in their entire lives. Whereas in other countries, especially the least developed countries, they may have 4 or 5 or 6 births, right? So that increases their chance by 4 or 5 or 6 times. So if we look at the maternal lifetime risk of maternal death, again, this really illustrates the disparities and injustices in this indicator. 1 in 36 for sub-Saharan Africa, and 1 in 200 for South Asia. If we look at compared to high-income groups, 1 in 3,300 women are expected to die. Well, the good news is we have made very important gains in eliminating maternal or reducing maternal mortality across the board, really, since 1990. So we can see by 2015, in many places, we've about halved maternal mortality. So that is the good news, but we do still have a long ways to go. The SDG adopted a target of achieving a global maternal mortality ratio of less than 70 per 100,000 live births by 2030. So that's the global average MMR target of less than 70 per 100,000 live births. So that means that in order to achieve this, it's going to require every country to reduce its national maternal mortality ratio by about 2/3 in that time frame. And that's not probably going to happen. It is not even going to get close. And so there's definitely an urgent need for us to continue to make important strides in improving maternal health and survival in order to meet this global target. So what are the top causes of maternal death? So women die as a result of complications often during and after pregnancy and childbirth. Most of the complications develop during pregnancy, and most of them are preventable or at least treatable. So the major complications that account for about 3/4 of all maternal deaths are just 4 of them. They're severe bleeding, which usually occurs after childbirth, infections or sepsis, also usually after childbirth, high blood pressure or preeclampsia, which happens usually during pregnancy and can be detected, and complications from delivery, including unsafe abortion. So these almost all of these, again, are preventable. All women, if they have access to, good maternal health care before they give birth, so throughout pregnancy and then during and after childbirth, we can really prevent most of these from happening. We know certain women are more at risk of maternal mortality also, and this includes younger women and women over age 35, women who have had more pregnancies and more children are more likely if they have short space between their pregnancies or have had a high-risk pregnancy in the past, or if they have no access to good maternal care. And then some of the risk factors for this include low education, certain religions, nutritional status, especially low weight of the mother, stunting or low weight, if she has comorbidities or other existing health problems like anemia, for example, or malaria or another infectious disease. And I think what's most relevant for Indonesia is we know that distance to the healthcare center is a huge risk factor. So geography is a huge risk factor. In terms of services, the WHO has come up with the pillars of safe motherhood, and it talks about, in addition to things like family planning and education, it talks specifically about maternal health services that are important. And that can include antenatal or prenatal care, skilled birth attendants and a facility birth, and emergency obstetric care if needed. So here's where we're going to talk more about culture. Why is antenatal care so important? Or there are a lot of things that happen with antenatal care, right? They monitor, they take the weight, they measure the stomach, they screen for high blood pressure and other complications. They do blood tests to check for sexually transmitted infections or anemia or HIV, those kinds of things. But one that I really want to focus on in terms of culture is it establishes a relationship with the healthcare center, which we know from studies around the world will improve the chance that the woman will go back to use delivery care when it's time to have her baby. So let me tell you a little bit more about that. So when I did my work and lived in the very remote village in Bali on the east side, where very few tourists ever go, it's very, very dry area with, at that time, no running water and no electricity. And you had to ride on a motorbike, on the back of a motorbike, since I didn't know how to ride a motorbike, up this volcano for about half an hour to after you get to the kind of off the main road. Then you have to go up this slippery and sliding up this road to get to these villages. And there were about 13,000 people living in these villages. And most of them, because they almost had been forgotten by the government. They had few services there. They did not go to school past primary school, so most of them did not even speak Bahasa. They only spoke Balinese. They mostly lived on agriculture. They were quite distrustful of people, strangers coming into their village. And, you know, because they didn't have like running water or much access to healthcare, they had a lot of health problems. They, you know, weren't able to like wash their clothes very often. They didn't have access to sanitation, that kind of thing. Well, imagine, so there was one health clinic at the bottom of the road. And that health clinic had a really fantastic doctor, some nurses, some midwives. But it was really rare for anyone to go to the clinic. They avoided the clinic. And, you know, you wonder why. Is it just the transportation problem? Is it just the fact that they may have to walk an hour or two to get to the health clinic? And we found out that no, it wasn't, because we started up the Posyandu, which hadn't been active in decades. We started it again, where we convinced the providers from the clinic to go on the back of the motorbikes up the side of the mountain and to visit the villages once a month. Well, when we started, no one came. Even though we were bringing the services to them in making it convenient. And we thought, oh, this is going to be so fantastic. Hundreds of people are going to show up and they're going to be so happy to see a midwife or a nurse. No one came. That was one of my most important public health lessons, I think, early in my career, is you cannot underestimate the other barriers. It's not just about access. And what we found as really the major explanation for why people weren't coming is because they didn't trust the healthcare providers. The healthcare providers were people from the big city who were well-educated, university educated, who did not speak the local language. They mostly, only spoke Bahasa, and if they spoke Balinese at all, it was the higher caste Balinese, not the kind of Balinese that the local people spoke. And the local people felt like they were very much being judged. They felt like they didn't like them, that they were disgusted by them, that they were too dirty, or they were too smelly, or they were too uneducated. And so they felt like there was a lack of respect, and they were afraid that they weren't going to, because of these cultural differences that were enormous, that they were not going to respect their beliefs and wishes and their cultural practices in that village. And so they didn't go. Instead, they chose to basically give birth in their fields. And they talked about taking a bamboo stick when their bellies got big, and they would take the stick out to the field. And when it was time for them to have the baby, they would have the baby in the field, use their bamboo stick to cut the cord and walk the baby home. Well, you can imagine that there were a lot of problems, right? There were a lot of of complications, both from in the mother as well as the baby. And so it really took a lot of just making connections with people to form trusting relationships, to see what kind of care was going to be offered at the clinic or with the midwife, and to assure women that they were going to be respected, and their culture was going to be okay, right? Their practices were going to be okay and respected. So I think that was a very good lesson. Facility births, it's really hard to get a woman to go to the hospital if she has not been there before. If she has not had a prenatal care visit with the doctor, it's very unlikely that she's all of a sudden going to decide when it's time to give birth, okay, I think I trust these people, let me go see them. No, it takes some time to build those relationships. We know that often traditional birth attendants are preferred, right? But and we'll talk about why in a minute. But skilled birth attendants is really, really crucial to ensuring safe motherhood. Skilled birth attendants can help manage complications. They know what to do in the event of emergency. They can provide education and family planning and support. And in fact, skilled birth attendants are the single most effective intervention in ensuring safe motherhood and that women don't die. So again, we have made important improvements in increasing over the past 20-something years, increasing the percentages of births taking place in health facilities. But there are some regions, and it makes sense, South Asia, for example, and parts of Africa that have the highest maternal mortality are the places with the lowest coverage, the lowest percentages of births taking place in a health facility. And then I talked about the importance of emergency obstetric care. So this means, basic services like antibiotics, manual removal of placenta if it's required, or assisted delivery if it's required, but then also more comprehensive services should include things like performing C-sections if necessary, or resuscitation of newborns if necessary as well. So we often use in maternal care what's known as the 3 delays model. And this helps to explain where the delay would be and where we could better target, interventions. So the first delay often happens when a woman or her family just doesn't seek care at all. The second delay occurs when she tries to get to care, but maybe there's problems with geography or transportation, right? Both of these delays relate to access to care, but can also involve community and family beliefs, of course, as well as things like affordability of care, the cost of care, or ability of transportation, things like that. And then the third delay is actually delay once she arrives at the health facility. So this one is more about the health facility factors like availability of staff people or equipment, right? Or quality of care also might be one. So we know that the use of maternal health care services, there are huge disparities, and that the lowest rates of use often belong to the most marginalized groups. People in rural areas, people with low education, or low income and ethnic minorities definitely have lowest rates of use. And so, yes, there are many barriers like cost, access, quality, not knowing where to go, geography, but cultural beliefs are also huge determinants of care, of accessing care. And some of these include, for some cultures, they believe it's believed that childbirth is just a natural experience, and that everybody's been, women have been doing it since the beginning of time. Why do we need to have an intervention now? It should just be natural, and you should be able to give birth at home. Another cultural belief, which has been seen across many cultures, is that endurance of pain is actually valued. It's a virtue. You should, as a woman, be able to endure this pain, and that if you don't, you're seen as weak. In some cultures, they believe it's unnecessary to give birth in a facility because it means that you're sick. And childbirth doesn't mean that you're sick. It just means you're having a baby. And so you should not go to the hospital. And again, you might be stigmatized or shamed in your community or among your family if you want to give birth in a health facility. Other beliefs might be around fear of medical procedures, or maybe you have a certain birthing position that's common in your culture that you think you're not going to be able to use if you go to the hospital. Or maybe you really want your family there, but you're afraid nobody's going to respect that when you get there. I mean, look at what often childbirth looks like. It's very much medicalized. You're laying down and all these sterile instruments. People are looking down there, right? All these strangers. That looks pretty scary. All these lights. It looks much more like a surgery than a natural process. So you could see how women might be scared. It's hospital or facility-based care can be seen as very impersonal, where you have little control or little autonomy, where you may be embarrassed to, have to have a lot of other strangers looking at you. So there's a lack of privacy. There's this belief that you must just be passive and compliant, and that you have to agree to whatever your healthcare provider advises, even when it's against your own preferences or beliefs. And so that's scary. That's not going to encourage people to go to these facilities. And so there's this perception of these formal providers that we are going to need to address and to change, that formal providers aren't to be trusted, or don't understand the culture, or don't respect women's autonomy. Because traditional birth attendants are very much preferred in many societies for this reason, because they know the culture, they come from that culture or community, and so they may have familiarity with the local rituals and medicines, and will be much more trusted. I wrote a paper about traditional beliefs in Asia around pregnancy, childbirth, and postpartum. And, there were a wide variety of beliefs, and many of them are not harmful in any way. So why do we need to discourage this, right? Why do we need to only push this very biomedical concept, medicalization of motherhood? So things, some taboos. Okay, you shouldn't drive a car. You shouldn't attend a funeral. The husband shouldn't cut his hair or climb a tree. Family member can't hammer a nail. Can't lie on your stomach. Or you eat spicy foods and your baby is going to be born hairless. Or you drink coffee or tea and your baby is going to be not smart. In some cultures, you can only eat up to half a banana, never a whole banana while pregnant. Okay, these may seem silly, right? But who cares, right? Do we really care about whether a woman is only going to eat half a banana or a full banana? If us respecting that belief is going to encourage her to come to the facility to have a safe birth, isn't it important to understand, to ask her and to understand these beliefs? Because many of them, again, are harmless. And so placenta rituals, confinement practices, purification rituals, hot and cold avoidance, use of plants, so many of these they're easy for us to respect, if that means, right? If that means that women are going to feel more trustful of the healthcare system. And in fact, we know that there's now a term that we use called maternal disrespect. And maternal disrespect, it occurs in all societies, certainly, but is more prevalent in low and middle income countries. And there has been a lot of recent, probably the past 10 years or so, research about this. And it is quite dramatic, I would say, and prevalent in some places, that it's quite shocking that women report physical abuse during childbirth, discrimination, non-consensual or non-confidential care, that they may be detained, denied access, or even abandoned during the process. So these are categories, there's a whole continuum of from more subtle, just disrespectful, all the way through real humiliation and shaming to even overt physical abuse by healthcare providers. And so this is another disconnect between providers and patients and their families, often related to cultural differences and misunderstandings. So why is this important, right? We found that if this hospital or facility care is very impersonal, if they're mistreated by healthcare workers, if their privacy is violated, or they're embarrassed or shamed, or feel that it's culturally unacceptable for them to speak out or to ask for something that they need, and instead need to be passive and compliant, we are not going to convince any woman and any family to go to that clinic to give birth. Instead, we need to understand and appreciate their beliefs and practices. And we know we can encourage more women and families to come to access services if they know their practices will be respected. Okay, so that's, I think, really important. We need more understanding and more research, more cultural competency among maternal care providers. We need to understand why women seek care in informal caregiving settings, and also make the link between safe motherhood and prenatal or antenatal care. So it requires more community outreach and education. So we know some of the key takeaways from this portion of the talk are that there are lots of barriers to maternal health care service utilization, but culture is really a huge one. And yet maternal mortality is actually still a leading cause of death among some women, but despite it being almost completely preventable. All right, so the last part of my talk is idioms of distress, but does anyone have any questions or comments so far? Should I move on? Okay. So as I mentioned, this is the last part talking about more mental health. So idioms of distress. What exactly does that mean? Idioms of distress basically just means the way that a disease is manifest and is explained. And so usually we refer to this in terms of mental health issues. So particularly emotional or psychological or mental health issues may be explained much more by physical symptoms than by mental or psychological symptoms. And the reason is because often it's culturally more acceptable to talk about physical symptoms than about emotional or psychological symptoms. So many symptoms, then mental health systems do have a cultural basis and incorporate and are mediated by cultural beliefs. So some examples might be talking about stomach problems, talking about weight loss, talking about substance abuse or anger or insomnia, instead of talking specifically about fear or anxiety or panic. So again, idioms are of distress are socially and culturally mediated, meaning that in each culture there is often what seem appropriate way of experiencing and expressing distress. So often these manifestations then will be readily accepted by the family. And we know that idioms of distress may help those who have weak support systems or limited opportunities to discuss problems or feelings or to seek help, may have to resort to using a different way to explain what they're feeling. So in a way, these can be considered adaptive responses in circumstances where other ways of explaining your problems are not really acceptable in your society. So that might be, again, you might not feel it's okay to talk about your panic or your crying or your feelings of sadness, but it is acceptable to talk about how you have headaches or you can't sleep or you have stomach aches. So let me give you some examples of what we call now cultural concepts of distress. So cultural concepts of distress is defined as the way that cultural groups experience, understand, and communicate suffering, behavioral problems, or troubling thoughts and emotions. So it's a broad term that encompasses certain behaviors or illnesses or conditions that are generally very specific to one culture, or at least they're perceived to be really specific to one culture. So these behaviors are usually deviant, right? Not typical behavior. And that's what makes them the reason for distress. We used to, as I mentioned, we used to use the term culture-bound syndrome, but the DSM-5, so that's like the official international handbook of psychiatric disorders, now refers to them as cultural concepts of distress. So it's usually a mental illness that's only found in a certain culture, only manifests this way in a certain culture. And they're, usually they even have a local name or terminology. So here are some examples. Maybe you've heard of these before, but these are some common examples of these culture-bound syndromes. Susto comes from Latin America, which means that your spirit leaves your body when you get scared. So it throws off kind of your equilibrium, and it results in loss of appetite, restlessness, depression, introversion, isolation. Amok is from Malaysia, and it has to do with men who is suffering, gets insulted by somebody, and then kind of goes nuts with anger and tries to kill people around him or hurt people around him. And this has actually, the same thing has been documented in some other cultures, but it primarily comes out of Malaysia, this term. Koro or Yang Shuk is another one. This is Chinese men who believe that their penis has retracted into their bodies. And what this causes is intense panic. So they have all the symptoms of anxiety disorder. They have sweating, they have heart palpitations, they can't breathe, they can't see, they have panic, body spasms, even paralysis. But in that culture, it's not okay for men to express that they feel anxious. And instead, they come up with this alternative explanation, which is similar to Dot, which comes out of South Asia, mostly men, who somehow believe that they have lost their semen. And this is a great cause of anxiety and fear and panic. And they have not biologically lost their semen, but it's a way for them to explain, right? To blame something else for their cause of anxiety and panic. So it's really fascinating that it's in these cultures, it's not acceptable for you to talk about mental illness or depression or anxiety. And instead, you have these alternative explanations that have evolved out of your culture. In South Asia, a man to lose his ability to procreate, right? If gender roles are very important and attitudes about masculinity, fertility, right, have a lot to do with your male roles in society, the idea that you have lost your semen is going to be very troubling to you. And so that's a way to explain those feelings, even though it's not biologically true. And so here's some other ones. Lata maybe you've heard of that. Okay. Ode Ori, similar to schizophrenia, but it's in Nigeria explained as spiritual attack. And Piblokto, which comes from the Arctic, which again is another one, like a hysterical reaction, like irrational, dangerous, and very strange acts that happen to women that are around a mental illness, but they were explained as something else. I think that's fascinating, really, really fascinating. So in my own work, we found in Mongolia something related to this called Sav Kuruk, which when you ask women, it sounds very, very similar to postpartum depression. I view all of the symptoms are very, very similar to what we would call postpartum depression. But it really came out of, first you have to have a big shock, and then all of a sudden you get these symptoms. And when you ask women, well, and families, like, well, who's more likely to get this condition? It relates very much to family and spousal support. So women who don't have a lot of family or spousal support are much more likely than of developing Sav Kuruk. So it's not explained much as a biological condition, because the primary symptom, a way that it's kind of manifests, is anger. Oh, women who are angry after they give birth, oh, that's because they have Sav Kuruk. And it's because they're angry that they don't have enough help at home. So it's really, I think, fascinating. And it also means that we must understand these beliefs if we're going to be able to screen women and talk to women about their problems. If we're just using some standardized depression screening tool from the WHO or from Edinburgh scale or whatever, that we're going to apply to every culture in the world, that's probably not going to be effective. So we have to think about culturally tailoring the way that we're screening women and we're talking to women about postpartum depression, or talking to people about some of these other problems, again, that are often stigmatized and not socially acceptable. So it's important to note also that these culture-bound syndromes, again, go back to this idea that, these Western people were going into these, what they called uncivilized societies, and their diagnoses really had very limited understanding of the cultural context. There's very limited research about these culture-bound syndromes because they were just seen as like, oh, well, that only happens in that one little place in the world, not that important, right? So I think we need to also consider that our DSM, our diagnostic tools and our diagnostic, descriptions of mental illness are very much based on Eurocentric, Western-centric beliefs, white, middle, and upper class men who didn't really understand the cultures that they were going into. And so we're finally starting to frame these idioms of distress and explanatory models in different ways that is much more appropriate for that culture. And so that's huge, I think. But it's important to note that our own definitions of mental illness, even though this is like the international book of diagnoses, the gold standard for psychiatric diagnosis, is culturally biased towards Western societies. So summary, in the way that people perceive, interpret, respond to illness and disease does vary by culture. And in many cultures, it's much less focused on a biomedical description and understanding. And that even people with the same disease may describe and understand their own diseases very differently. We need to consider idioms of distress and culture-bound syndromes and the way that diseases manifest in unique cultures, and that requires a much more nuanced understanding and appreciation of local cultural beliefs and practices. So finally, I just wanted to mention, going back to the first part of our discussion today, what is about the APRU Global Health Program and potential collaboration opportunities that I would love to let students and also faculty know about. So just a quick description of what the APRU program is. It's a nonprofit network of 60 universities in the Asia Pacific, representing more than 500,000 staff and 2 million students. It represents 19 economies in the Asia Pacific. The Secretariat is based in Hong Kong, and the organization has been around for more than 25 years. So there are actually 61 universities now, including several in Australia, Hong Kong, USA, and Japan, Korea, and then there's one in Indonesia, Universitas Indonesia. But what I would like to tell you is the good news is I welcome even universities that are not yet members to join the APRU Global Health Program. So you are all welcome to participate in our activities. One of your next speakers coming up soon from the University of Malaya is on our advisory board. Sanjay Rampal is one of our members. We also have Budi Haryanto from Indonesia representing Indonesia on our board. One thing I want to mention, and this just we just concluded this, but we are going to open this up again in September. We offer a free mini certificate in health research ethics for students. This idea really came out of the need to train more of our students to conduct ethical research on human subjects, because many of you have to complete research projects as part of your education and training. So this is a training of 12 hours, which includes 6 hours of live time in groups with us all together in one happy family. And we have guest speakers. We have 6 international, like super famous bioethicist speakers. And we have more than 30 facilitators who help in very small groups, about 10 students and 1 facilitator per group. We review real-world case studies using a book by the WHO. And so it's fantastic to be in a group of students from Mexico, Japan, Malaysia, Philippines, Indonesia, Ecuador, all talking about a real-world case study in health research ethics and comparing across countries and learning about the principles that we use to develop ethical research. As I mentioned, the next event is taking place in September. It's a 1-month program that includes 3 2-hour sessions, and I will make sure to send you the information. We have a waiting list of around 1,000 students, but most of them are from the Philippines, and I prioritize, I give quotas for each country because I want to make sure we have a lot of representation. So we always have plenty of spots for Indonesia because you're very close to my heart, and I'm happy to accept you into the program. Then the other thing that I wanted to mention today is our annual Global Health Conference. This year is taking place for the first time ever. It's our 16th annual conference. It's taking place for the first time in Latin America in October in Mexico City. So you may be wondering, why am I talking to you about a conference taking place across the world? The reason is because we have an annual student poster contest. And we have prizes for first, second, third place for both undergraduate category and graduate category. And all posters submitted to our conference are accepted. Even if you cannot attend in person, we will be displaying your posters at the conference. Hence, you can put on your CV that you had a poster presentation at an international scientific global health conference, and that helps you in the future. And of course, you may be able to win one of the 6 prizes as well. So that opens in less than 2 weeks. We will be accepting posters for about 2 months. So if you have any work that you think might be appropriate, please submit your poster, and I'll make sure to pass on this information to the leadership. Those are my references. So thank you so much for listening. And I'm happy to take any questions or comments that you may have. Thank you.
Thank you so much for Mellissa Wilters for all the talks, that amazing talks that we hear. It's about the ethnocentrism and also cultural relativism, and how do we perceive our mental health problems or maternity problems in our culture or different culture with the view of the cultural relativism. Okay, before we're gonna move on into the Q&A session, maybe participants in this Zoom want to ask the question directly to Mellissa?
Sure.
Is there anyone want to ask the question directly? Okay, there's 2 and 3 participants who raised their hand. So we're gonna start from the first one. Okay, Gema Kaila, silahkan. Maybe in English or Bahasa.
Okay, thank you for the opportunity. I would like to say thank you to Mellissa for the lecture. It was very insightful. I appreciate that. My question, or the thing that I want to discuss, is about the fact that a lot of our knowledge regarding medical beliefs or theories, as you said, are very much curated by the Western culture, and this becomes a problem, knowing the diverse culture that indigenous people or, non-white people have. And I think, what are your opinions about it? And should it be a possibility in some ways for BIPOC indigenous researchers to be a lot more recognized by the Western culture and also their own culture to give an accurate and non-biased views about their culture's medical approach? So there's that. That's my question or / discussion. Thank you.
Thank you so much. That's fantastic. I think you made an excellent point that many of these beliefs are biased towards Western cultures. And I think it's only been in the past few years that I've seen a better appreciation of, for example, indigenous knowledge systems even at our own annual conference that I mentioned this year. We are having a whole section on Indigenous health, and I see that trend. So I think it takes both sides. I think it takes the West to acknowledge that that our understanding and our gold standard diagnostic tools are very biased, and then it takes the non-Western world to help educate us, and to do research on different alternative and superior forms of knowledge that are going to be much more acceptable, right, and much more relevant in your own cultural context. So it really does take both sides, and so I hope that we'll continue to see the development of more research and understanding about these nuanced understanding of culture and health.
Yeah, that's an interesting thing, because it tends to be, because I think in our culture we tend to kind of underappreciate our own culture. So we sort of think that the white people's opinions are a lot more better than our own culture, which is very rich. And I think, yeah, there needs to be a lot more recognition for our own culture, even from us non-white people, I guess.
Absolutely. I'm glad you said that, because it's a bit of a sensitive topic maybe to say that, but it's very, very true. I earlier this week I was in Ecuador giving a talk at a global health conference, and my topic was authentic partnerships in global health work. And that was exactly my my point, is that the global South needs to also recognize and appreciate its own strengths and form collaborations with other members of the global South, instead of always or often looking towards the global North as being like, knowing everything. Because it's really very valuable to ensure that we have bi-directional exchange of ideas and understanding and knowledge production that comes out of the global South as well.
Okay, thank you for your answer. I appreciate it. I'm giving it to the moderator. Thank you so much.
Thank you.
All right, thank you very much, Kemak Halia, for asking. And then next we have Salman Brinan. Okay, so Salman, you can ask to Mellissa.
Okay, hi, hello, can you hear me?
Yes, hi.
All right, first of all, I'd like to thank you for the great presentation, Mrs. Withers. So I have a question about health promotion and culture. So what if we are dealing with a group of people or a community that are ethnocentrist and quite seclusive towards outsiders and new ideas? How should we approach the situation so that it won't seem to them that we're forcing our beliefs, and so that our health promotion can have the desired effect? Thank you.
Great. Thank you. Great point. Yes, it is tricky, but I think the most important thing is to work with community, right? We can't go in to a community as outsiders and say, hey, we're the experts. We're going to tell you what to do. Your beliefs are no good. Instead you have to think and behave like us. That is not going to be very effective or acceptable. And so really the way that we can gain traction is to have internal champions in those communities that are respected, leaders or people that can help change, beliefs or practices within that culture. And it takes time to develop those relationships. And it's hard work sometimes, but without it, we will not succeed. If you're not an insider, it's going to be very, very hard to change, to help to promote health and to change behavior. So that would be my advice.
All right, thank you, Mrs. Withers, very great answer. If you don't mind me asking, have you ever, or do you have any experience with, let's say, a seclusive group of people or community in your line of work?
Yes, absolutely. So I've worked in several situations where I was definitely the outsider. One example is my work actually in Bali, right? I was the first Western person to ever spend the night in that village. So I worked with the community development organization, and they did sometimes have Westerners that would come, and they do like the little tour of the village, and they'd stop at a couple people's homes, and because they wanted to get donations, right? So they'd give them a little tour. They'd show them how there were so many needs for water and healthcare and education, hoping to that they would give money, and then they would be gone. And so now it's like 15 months later, right? I'm sitting around this fire, and I'm talking to the community about, hey, remember the first time I came to your community? And I'm this like outsider that is not to be trusted. I don't even speak your language at that time. And why did you accept me so warmly? Why have you made me feel like I'm truly a member of your community? I've gone to your temple ceremonies. I've held your babies. We've talked about really sensitive topics about childbirth and family relationships, and why? And they said, well, you know how we knew that we could trust you? And I said, no. And they said, remember when the first time you came to our village? Yes, I remember that. You drank our tea. And I was like, what are you talking about? And they said, we noticed that they called me the bule, right? The like white buffalo, right? I was like, really? Can't we come up with another name? But nope, they called me. Remember when every other foreigner person came to the village, and they would come to our house, and we would welcome them, and we would give them this tea, and they would not drink it. And I remember that day thinking, oh no, like there's no running water here, right? They can't wash their dishes. Who knows if this water's safe? There's like so much sugar that all these flies are like stuck to the top of the glass. I'm afraid that if I drink this tea, I'm probably going to get sick. But I think it's really important for me to drink the tea. And so I drank the tea, and luckily I didn't get sick. But they noticed that. They noticed the difference between someone who is actually there to have an authentic partnership versus someone who is there and like, ooh, grossed out by some, dirty village, or not washing dishes or whatever. They noticed that. And that made the difference in terms of whether I was accepted in that community or not. It was a really important lesson for me.
Thank you, Mrs. Withers, for sharing. That is really awesome. So it's all about respecting the custom and the culture, right? Thank you.
Absolutely. Thanks for the question, Salman.
Okay, up to the next question from one of our lecturers. Miss Ira, maybe want to ask it directly?
Yeah, okay. Thank you, Dr. Withers. This such a great experience hearing your lecture today. And I'm one of the lecturers at the Health Promotion and Behavioral Sciences Division. And I understand that this is a huge challenge for us dealing with ethnocentrism, right? Ethnocentrism, so where people value their culture more than others. Now, I wrote my question in the chat room, but I was wondering um, how should we approach for the community who think that their culture is above all others. For example, like this, when I was in NTT, for example, there are they have these certain rituals that the mother and the child should be exposed with fumes, so it will bring good luck to the mother and the children. But we know that this is wrong practices. But if we force them to stop these practices, then I was worried that they have this huge amount of psychological barriers that will affect their mental health. They will always think that, oh, I was stopped while doing this ritual, so now my babies get sick a lot, and then now I'm not that healthy and everything. So there are certain side effects if we actually force people to stop the certain rituals. But we know that is actually the wrong one, right? We need to stop that for the good health of the mother and the children. But the problem is that these problems happens after the ritual is finished. So it is hard for us to blame these certain rituals as the cause of their health problem after that. So what do you think we should do in dealing with ethnocentrism in this type of cases for public health? Thank you.
Thank you, and thanks for sharing your own personal experiences. I love to hear like actual stories of what happens, the challenges in this type of work. Yeah, it's an important topic, and we have other examples of this, from child marriage, right, to certain practices in terms of gender inequality. We have practices in Nepal around extreme isolation after giving birth that have led to deaths of women and their babies by freezing to death in these huts and things. So we definitely don't want to, support practices that are harmful, even though there may be traditional beliefs. But really, I think what happens is that if we go in as outsiders and say, you can't do this, it's not going to work. Instead, we, again, really need to work from the inside out. And if we can find some people in the community who are trusted, who can work against these practices and explain to people using their own understanding of their culture, because they belong to that culture and that community, is going to be much more effective than us going in and trying to say, oh, that just is harmful. And so that approach does take usually more time, which is a huge limitation. But really, I think that's the only way, is finding someone who can get on board with what you're saying, and then who is going to be able to disseminate that information, convince people in the community to change their practices.
Okay, thank you for the insight. Yeah, so we have to use the local people there that they trust, right? And then ask them to be the agent of change for this community. So maybe it will get through easier than us, the outsider, that actually try to change their way of life. Okay, thank you, Dr. Withers, for your explanation. Thanks.
Yeah, thank you. Thanks for attending today.
All right, thank you very much, Ms. Ira. Up to the next questions, we have the question from the chat box. So there is Al Gefarik. Maybe Gefa would like to ask directly. Okay.
Okay. Thank you for Mr. Twitter for the insightful explanation. I would like to ask, like the explanation before, every community or entity has a different definition of health and medical or even cultural norms about that. I asked if there was a culture within a tribe that could be said to be very contrary to the concept of biomedical health, which could be said that dangerous for health, how to react it, and what should be done. Thank you.
Thank you. Yes, absolutely. I think working within the community is really important. You know, it's been really interesting in the using the example of maternal health, that some of the people that have been the biggest champions and the most successful at encouraging women to seek formal care are the traditional healers themselves. So if we can try to incorporate these, people into the more formal practice, saying, hey, let's provide education to you. And these are the practices that would be harmful. These are the red flags. These are the times when we want to train you to be able to recognize a complication and refer the woman to the hospital or to the clinic. They were very much on board with that because they don't want to be blamed for someone going to see them and then having a death or a complication, right? So instead of just pushing them out and alienating them and saying, oh, you have no training, you're bad. If we can be more respectful and more inclusive without promoting behaviors that aren't and practices that are dangerous, I think it's going to be much more effective in that community.
Okay, thank you, Mr. Reader, for the answer.
Yeah, thanks for the question. Nice to meet you.
Okay, up to the next question. It's from one of our lecturers in Universitas Airlangga, from Ms. Riris. There are two questions. Would you like to inform the best practice experience about cultural intervention to improve maternal health, particularly to change maternal perspective and behavior regarding delivery care to healthcare, such as doctor or midwifery, not to traditional attendants? And the second question is, what about cultural concept distress or mental health in adolescents? Is it the same between cultural concept distress in adolescents and adults? Maybe Mellissa can answer.
Yes, thank you, Ruth. Yeah, so a good example of the first question is in my village where I lived in Bali. I did some interviews with all of they called them dukun beranak, so like a traditional healer specific for birth, right? And they were all men. And so I talked to them about like, how do you become this healer? They were very, very respected within their communities, right? Is it like a training? Is it something that's passed on from father to son, or for like, how do you learn about this? Like, I'm really like trying to delve into the whole training. And I remember one of them said, oh, well, I had a dream one day that I should become a dukun, and I woke up the next day and announced to my village that now I'm a dukun. And I was like, what? Right? Like my mind was a little bit blown. Like, what are you what I wanted to say is like, no, like, what are you talking about? Like, this is really scary to me. Maybe this explains why there have been so many infant deaths and things in this community, but that wasn't going to work by just, right? These were very trusted and respected members of the community. And so I couldn't just say, what are you talking about? That's not right. Like, how are you doing this without any training? And so instead it was a process again of working with them for them for them to understand like limitations and what was okay to do and what was not okay to do, and when it was important to refer people to formal care, and why some of these other services that were actually being provided by the midwives and the healthcare clinic were useful. Why did you need to have a tetanus, vaccine, or get a test for anemia, or all of these other things that they weren't providing? But once they understood, like, okay, well, we could do both, and here's where I should probably refer, and that it worked out great. It worked out so much better. We saw a huge increase in maternal health care utilization by working with the traditional attendants. So I think that was a good lesson. And then the second question about what about cultural concepts of distress and mental illness in adolescence, and is it the same between adolescents and adults? I would say no, it's not always the same. It could be very possible that adolescents lack support systems, or even lack understanding of their own mental health issues, or may not feel that it's acceptable to talk to people about what they're feeling. And so they may explain their symptoms in very different ways that someone who's an older adult, who's, more confident, or doesn't maybe feel the same level of embarrassment or shame. And so it's really crucial to really listen and ask questions, and listen to the words behind what they're saying and the meaning behind the words, instead of just trying to like force our own definition of a mental health or a physical health problem onto the patients or the people that we work with.
All right, thank you very much. To Bu Riris, maybe you want to give a feedback, or is it enough? To Bu Riris.
Well, Riris is also an expert in many ways, so I'm happy to also hear what you have to say about this. So I can learn from you as well.
Okay, thank you so much, Miss Mellissa. Actually, I'm a little bit study about stress, and particularly about adolescent stress. So I need many information from you. I think your explanation about cultural concept of adolescent is a very important thing. So for the next, maybe I can discuss later about it from you. Okay. Thank you so much.
Yeah, thank you. Happy to hear more about your work and to continue this discussion later on.
Yes.
All right, thank you very much, Ibu Riris, for asking. And then we have like 5 minutes left. Maybe one final questions to the participants who wants to ask. There's still 5 minutes left, so maybe you still want to ask to Mellissa Withers. You can ask directly by using the raise hand feature, or you can type down your questions in the chat box, because we still have 5 minutes left for the Q&A session. Is there any other questions?
Well, I can put my email here in case people want to contact me later. I'm happy to continue the conversation also. Wow, the English I heard today was absolutely amazing. Very impressive also. So,
thank you very much.
Yeah.
Okay, so all the participants, is there any questions? Okay, I think we're enough in the Q&A sessions. Or maybe if all the participants wants to ask later, as you mentioned before that they can contact you via email, right?
Absolutely. I'm happy to hear from anyone who would like to contact me, and we can continue discussions, and I can answer any questions you might have, or you can tell me about your own thoughts and comments.
Exactly. All right, so thank you very much, Mrs. Withers, for the insightful and explanations and presentations coming from you. So it's been 30 minutes for this session. I am really sorry due to the limited time that we have here. We sadly have to end the Q&A session.
Yes, and thank you so much to Mrs. Miller again for this really great opportunity for us to sharing this insightful thoughts and explanation and having this discussion. And we do believe that these topics will really important to all the scholars, all the health promoter and also health practitioner in this Zoom, and also that we can learn that from this view, the cultural relativism, we can doing much more approach to the community. And once again, thank you so much to all the participants here who asked the question in this session, and we hope that we all get the knowledge and insight from this topic.
Absolutely. It's always been interesting to discuss about the culture and how it related to the health problem nowadays. Okay, so ladies and gentlemen, a good event never ends in the world. They take only a pause and keep us waiting for the next. So I hope that we can meet again at the next event to discuss other topics again.
And may all of you have a healthy and happy life.
Keep learning and be a blessing for others. I am Bagus.
And I'm Gabriela, as your host today. Good afternoon and goodbye. Thank you all for the discussions and the talks.
Thank you, Mellissa.
Thank you. Thank you, everyone.
Thank you, everyone. Thank you, Bagus. Thank you, Gaby. Thank you, everyone. Yeah, see you next.
Thank you.
Sampai jumpa lagi.
Sampai
Bye.
jumpa lagi.
Ini sampai jumpa lagi.
See you again.
Bye-bye.
Bye.
Terima kasih Bapak Ibu dan teman-teman yang sudah join, sudah hadir. Jangan lupa saya kembali informasikan kepada Bapak Ibu dan teman-teman yang belum mengisi link presensi untuk bisa mengisi kembali link presensi yang sudah di-share di kolom chat. Terima kasih.
Mbak Nanda, hostnya, Mbak. Silakan diakhiri. And for all. Mbak Resa.